My name is AJ Seth and I'm a consultant in sport and exercise medicine, and I'm clinical chairman of HSJCircle Integrated Care. So musculoskeletal services have a significant demand on our healthcare system. MSK conditions themselves are the single biggest cause of disability here in the UK, and the World Health Organization has actually defined lower back pain as the leading cause of disability globally. This has a huge impact on NHS resources, with 30% of all GP consultations being reserved for musculoskeletal complaints, and 25% of all surgical interventions being for musculoskeletal problems. This obviously affects NHS funding, with £4.8 billion of NHS spending going on musculoskeletal problems every year. Musculoskeletal care has traditionally been uncoordinated and inefficient. And this is probably because patients have complex needs, high demands, and multiple comorbidities. They often require multiple pathways such as pain, physiotherapy, rehabilitation, pain medication reviews, and this has made it difficult for MSK services to cope. So traditionally what that has meant is that patients have received fragmented care and poor experience. They've also been offered surgical interventions where perhaps conservative measures may have been far more appropriate. And this also means that commissioners are spending lots more money than they perhaps needed to and receiving poor value for money for their services. So there are lots of different approaches used by CCGs to try and coordinate musculoskeletal care better for their patient population. There's different levels of service that can occur. Triage-based services are the first level. This is where referrals from primary to secondary care are filtered, and this can typically stop about 20% of referrals. The next level up is innovation, and in community providers such as first contact practitioners, and what these are specialists that can go into different working environments such as GP practices and provide that expertise on musculoskeletal care. So the highest level of integration in the community is the prime provider model, which is what we run here at HSJCircle Health. And what this means is we take control of the patient pathway from the point of referral all the way to the end of discharge. The prime provider model has been adopted by CCGs in Greenwich and Bedford. This coordinates the system through a single point of access, collaborating with all the local providers and stakeholders to ensure the patient pathway is seamless and efficient. In Greenwich and Bedford, implementing the prime provider model has been hugely successful. We've managed to increase community provision of MSK services by 30%, drastically reduce orthopaedic referral, and save CCGs vast amounts of money. So I would encourage all healthcare leaders to become familiar with the musculoskeletal core capabilities framework, as this really provides a gold standard of how MSK services should be run in the community. I would then encourage leaders and commissioners to have a look and see what's available in your local community in terms of running an MSK service, and do a risk-benefit analysis to see what will suit your population needs. I would say that running a full integrated MSK service is complex and requires strong leadership and a specialist skill set. So I would encourage healthcare leaders to come see what we do here at HSJCircle.